Hi, my name is Dr. Brown. I am a pulmonary and critical care specialist that works with our ALS clinic here at the University of Utah. And today I'm going to be talking about breathing support and ALS. Specifically in this talk, we'll be talking about lung function. I don't have any current disclosures with any device companies, so I don't have any particular devices that I favor over another. So just introduction for you guys. Respiratory disorders are a leading cause of illness and death in neuromuscular diseases, including ALS. And timely intervention could prevent complications and prolong life. Management and monitoring of these disease progression may vary from one clinical presentation to another. And so not all this content will apply to every patient, so that's something to keep in mind. So to start off talking a little bit about how breathing works in general, you'll see on this part of the slide that's marked active, you'll see a diagram where you inhale air. And as you inhale, your rib cage actually expands because the muscles around your rib actually contract, and that pulls your chest open. And there's also a diaphragm, which is a large flat muscle which separates the chest wall from the abdominal cavity. And that diaphragm is actually going to move down as it contracts and to help those lungs pull open as well. And then there's a passive phase of breathing where the diaphragm relaxes and those rib cage muscles relax as well, and the air in your chest gets exhaled. And this other diagram shows it the same thing, but from the side, so you can see how the ribs move and how important the rib muscles or intercostal muscles are. And you can see the diaphragm pulling down as well on the active phase of breathing. So this is a model of the lungs, the chest, and the diaphragm here. The red balloon on the inside is the lungs. The plastic bottle is the chest wall, which includes the chest wall muscles. And the blue part at the bottom is the diaphragm, which is a large flat muscle that separates the chest wall from the abdomen. In normal breathing, when I contract the diaphragm by pulling it down, you can see that it opens up the lungs. When you exhale, it lets go of the diaphragm and it goes back up, and you can see that the lungs deflate and exhale. So inhale, exhale, inhale, exhale. The problem with ALS is that the diaphragm muscle gets weak. And when that contraction happens, the chest wall is also weaker as well. So when it pulls down, the lungs don't inflate as much and they stay partially deflated. And they lose that recoil as well, and so it's harder to exhale. So in ALS, you get less of an inhale, less of an exhale as well. And this next slide is just to show you what a normal chest X-ray looks like. You can see the diaphragm is at the bottom, and it's basically separating the lung areas. The lungs are black and on X-ray, and you can see the heart is sitting on the diaphragm as well. And you can see in this case, the lungs are black and they're filled with air. That's why. And you can see the airway that comes down the middle of the chest as well. So one of the things that we see in neuromuscular diseases that can be challenging is a condition called atelectasis or lung compression. And this can be due to diaphragm weakness or diaphragm dysfunction. And in this X-ray, what I'm showing here, you can see that the on the right side, that lung field, which should be black, is much shorter. It's about halfway up the chest. And that is because the diaphragm is dysfunctional on that side. And that means that that lung on that side is compressed or atelectatic. And in my mind, I always think of like a sponge being squished by your hand. That's what the lung tissue is like. And what can happen if you don't fully expand that lung is that lung can actually completely collapse. And that's what this X-ray shows here. You can see that on the patient's right side, it's completely whited out, and the trachea is actually deviated towards that side, and that lung is completely collapsed. Now, what you might see in a patient is that they'll have low oxygen levels, And they'll also have high carbon dioxide levels, and they can have shortness of breath and respiratory distress. So that's just one way to look at the lungs and think about neuromuscular involvement as well. And I'd like to introduce the idea of phases of respiratory involvement of neuromuscular disorder. This is actually based on something Doug McKim does out of CanVent, Ottawa. But I like it in the sense that it kind of splits things up into 5 phases and follows the progression of neuromuscular respiratory failure. So phase 1, patients can have no or minimal respiratory complications. And neuromuscular disease can affect anyone at any time, in the sense that patients could get a cold or a flu virus, or in current times, COVID as well. And weak breathing and coughing muscles are the causes of hospitalization and loss of life for these patients. Respiratory education regarding muscle weakness can prompt early assessment. So seeing your doctor early, calling the clinic early, and particularly with the individual who's had loss of ambulation or being able to walk. The other aspect in phase 1 that's really important is actually getting any vaccines that are available. We recommend, including the flu shot yearly and pneumonia vaccine series, depending on your age. As neuromuscular disease, including ALS, progresses, you can go into phase 2. These patients are at risk for respiratory complications, and that's when we do an evaluation for looking for this phase in clinic. And we're going to do this with breathing tests. We use the forced vital capacity, or FVC, it's a measurement of lung function, and the NIF, which is a negative inspiratory force, and another way that we look at how the diaphragm works. And then we talk about preventative strategies for patients as well. So what is the forced vital capacity, or FVC? It's a measurement of lung capacity and takes into account the respiratory chest wall muscles. And it's measured in clinic using a handheld spirometer in our clinic for respiratory muscle weakness. So a normal person will have, we compare it to predicted values, and a normal person will have a value that's 80% and above per predicted. Anything that's considered, anything that's 50% and below is considered to be significantly impaired. And the other lung function test that we look at is the NIF, or negative inspiratory force. You can also hear it called the MIP, or maximum inspiratory pressure. And so in this case, you want a more negative number. And if it's minus 60 and above, that shows us that it's significantly impaired diaphragm function. And we're doing this in clinic by having patients suck in on a device as hard as they can, in contrast to the forced vital capacity, where we have you blow out as hard as you can. And when patients are in phase 1 and phase 2, we'll test every patient that comes into clinic looking for respiratory impairment to decide if they need a device that helps them breathe and helps them cough.